I again welcome you all to this symposium. And what I'm going to talk in the next 30 minutes is the extension of what my friend Dr. Subhash Kaul has talked. That can we go beyond 3 hours, 4.5, 6, and now 9 hours. I think we are getting enough evidence now that we can extend our therapeutic window to 9 hours. And let me see what evidence I can give you to convince you about that. Thrombectomy trials, other trials of large artery occlusions have come up, but we must not forget one thing: in what percentage of patients do we see large artery occlusions? To start off, when I first heard the NINS trial and Subhash Kaul and I became friends there at their American Academy meeting, I was really excited when this study was presented, well knowing that it was not the first time that TPA was used. People had used urokinase, streptokinase, TPA, but these were in small group of patients from which you could not have made any significant conclusions. So this was a large trial. I thought it was a wonderful trial. A large group of patients, all categories of large artery, lacunar infarct, cardiomyopathic strokes. And after this trial came up, the biggest critics of these trials, which Subhash will agree with me, were the Britishers. And if you see, there was a very famous SITS trial where the least number of patients recruited in that was from the UK and the maximum was from Germany. Why? Because UK, they are such a conservative people, and if you talk to Warlow, who's the professor and head of neurology, retired from Edinburgh, where I've been, he would still talk critical about thrombolytic therapy. They have not grown beyond that. If you saw the first couple of presentations, I purposely introduced to talk about age, dual antiplatelets, minor strokes, myocardial infarction, to let you people be aware that how we have grown. I remember my first 15, 20 patients with eye thrombolysis, I used to sit there for 4 hours till the time the patient was not finished and everything was not done, because I was so mortally scared. Not that I was scared more than the patient. Though I had taken a consent, but that doesn't matter. I have the moral responsibility of the patient. I would sit there, and it would be subsequently, when we got the mobile phone app and you transfer the images, that I stopped going to the hospital at 2 o'clock in the morning. And thanks to my unit, that we are all on our WhatsApp, and we just send reports to each other, take decisions fast, so I don't go. But the last couple of years, I went regularly when we thrombolized the patients. Now please look at this slide. This is from the NEJM. This is the global, regional, country-specific lifetime risks of stroke in 1990 to 2016. So see the global risk of stroke. In 2016, the global lifetime risk of stroke from the age of 20 years onwards was approximately 25% among men and women. There are geographical variations in the lifetime risk, the highest being in our area, that's Asia, Central Europe, and the Eastern Europe, which you can very well see in this map. Why is time is brain? We all say time is brain. I would say yes, time is brain. But time is also the viable tissue in the brain. I'm more interested. I'm not bothered about 1 hour, 2 hour, 3 hour, 4 hour, 5 hour, 6 hours. I'm also bothered with the recent technology of diffusion, perfusion, etc., to see what is the viable tissue I have and can I reperfuse this tissue. That's why this is a very primitive slide, you may not like it, but this every second counts. In between you have the infarct, the red one, And then now that you have a penumbra, and now of course I'll come to subsequently later, there's more rethinking of the penumbra. As the infarct size goes up, the infarct becomes equal to the penumbra, and that is the area which represents the infarction which could occur over a period of time. Now, I would like you to see all those. This is the evolution of acute ischemic stroke over 2 decades. And I can tell you, I have personally read each of these trials. It's fantastic how we have grown, starting from NINS to ECAS, dawn, diffuse, wake up, extend. So that's what we have gone up to. Now here what you see again, the marked out areas which I have said. I would advise all those people who want to do stroke in the right way should really read these trials. And if you want, in my office, Dr. Dinesh has collected all these slides, all these studies, to please go through them. Now you see 2015, less than 4.5 hours. Now we're talking about less than 24 hours. So that's what we have evolved over a period of time. I will not talk about this. Subhash is very beautifully done. Does TPA work? Absolutely, absolutely, absolutely. I would go as strong as that. I will not go into further because Subhash has just talked about it. When we got 3 hours, the critics again, oh, which patient will come in 3 hours? 3 hours is a very short period. In Delhi, you would think Delhi roads are heavy, yeah, all that blah, blah thing. Okay, fine. You should still look for people who come within 3 hours. Then we went to ECAS 3. I don't think there's anything statistically wrong with this study, ECAS 3. And ECAS 3 enrolled patients till 4.5 hours. And they did equally well, but they made a conclusion. And the conclusion was, just because you have 4.5 hours, doesn't mean that you should wait for 4.5 hours. Earlier, the better. This is again, Subhash showed this slide. Early treatment remains essential. And if you see, the earlier, the better. Now this was the, again, Subhash talked about the IST3, which came in Lancet 2012. Dick talked about the benefits and harms of IVTPA. Within 6 hours of ischemic stroke, the third international stroke trial, which was again a randomized controlled trial. The third trial sought to determine whether a wide range of patients might benefit up to 6 hours from stroke onset. So 3, 4.5, and IST3 talks about 6. Now, what was the conclusions? The conclusions were not too bad if you say they were not too good. Despite early hazards, IST3 showed that thrombolysis within 6 hours improved functional outcome for patients in this study. 2, clinicians may consider thrombolytic therapy for a wider variety of patients, particularly those above 80 with or more severe strokes. More effort has to be made to increase the population of ischemic stroke within 3 hours of stroke onset. Fair enough. Clinicians must be assured that mortality is not increased by thrombolysis. When I started thrombolizing, if the clinician has referred the case to me, hemorrhage हो जाएगी तो क्या करेंगे? ऐसा कुछ नहीं करेंगे. I know there will be hemorrhage in 1 to 2 or 3% of the patients. And I can tell you, with the good wishes of the Almighty, I must have thrombolized a huge amount of patients. Fortunately, we did not have a single intracerebral hemorrhage. I'm telling you, without any, I didn't have a single patient who had an intracerebral hemorrhage where I had to sit the whole night. Now then, the era of imaging. How imaging changed the scenario of stroke. Now, most of you are aware, if you're not aware, that we do CT perfusion and we do MR diffusion and perfusion. Very simple techniques. Of course, slightly difficult to interpret, but techniques which will take you longer for your stroke patient. We all talk about mismatch. I'm sure a number of people in this gathering must be saying, oh, patient has got a perfusion, diffusion, mismatch. What is the mismatch? Historically defined on MRI as the difference in the volume between the diffusion weighted images and the perfusion weighted images. The DWI and the PWI should be by at least 20%, uncorrected, unthreshold, time-based perfusion parameters. It's an isotropic DWI. The limitations were, yes, when these perfusion study came, we knew the limitations. Everything has limitation. And our job is to get over those limitations. We knew that the parameters used by different laboratories in diffusion and perfusion were very different. So a lab sitting in France would say something, and a lab sitting in India would say something. Now this is just to show you a DW1, a perfusion varied images, and this is the mismatch. This is what you're looking for. Now here again, please concentrate on this slide. You have the red thing in between. That's the infarct core. And now you all know that what has been done in animal experiments, that the cerebral blood flow falls very fast in the inner core. Around the inner core is the right yellow area. In the right yellow area which you see, this is the part of the penumbra seen on DW1. The other yellow which you see is the part of a penumbra seen on perfusion varied images. And the blue one, they talk about a new thing where Mayank Goel from Calgary talks a lot about it. They call it the oligemia in PW1 images. And that is the complete penumbra. So here you are. If you have acute stroke, baseline, TPA 30 days, high chance of poor outcome if you don't reperfuse these patients. Now this is a very, very diagrammatic but a very interesting, which I picked up from Mayank Goel's article. Again, the core, the penumbra, the borderline between penumbra and the benign oligemia, and the area of benign oligemia. What is this benign oligemia? Benign oligemia is a tissue that is underperfused, but functioning normally, that will survive irrespective of improvement on the blood supply. And this area is dependent upon your collaterals. So if you go back to this slide, what does this surrounding area of oligemia depend on? It depends upon the leptomeningeal collaterals and the toxic and metabolic processes, including the peri-infarct depolarization. So this is what we are going to, and this is what we are going to achieve. Now this is of course absolutely diagrammatic representation, but very nicely given up in Mayank Goel's article recently in Radiology Journal.